Hello, everyone. Sorry for the delay. We had some technical issues. Here is, my name is Vangelis. I'm one of the Young ESPGHAN committee members. And we have here with us Mara and Jose, who are committee members as well. So Mara will start with the introduction of Young ESPGHAN activities. Mara, if you don't mind to unmute your microphone and share your screen, we can see your screen now. If you don't mind to unmute in order to listen.
I think, yes, I'm on mute. So welcome everyone. Thank you all for joining today's webinar organized by the Young ESPGHAN committee, where we'll be discussing one of the most pressing issues affecting pediatric health, which is the eating disorders. So I will start with a short introduction about Young ESPGHAN committee mission, which is to promote high quality research and training, to organize different activities for the Young ESPGHAN members, and also most important, to represent their interest within the council and society. Regarding some of our ongoing educational events, in 2024, the Young ESPGHAN Committee has launched a new project, which is called the Topic of the Month, and in which each month we have a new topic, and we aim to raise awareness regarding this particular topic. So which each week we have a different event, like today's webinar. Here are some of our previous Young ESPGHAN webinars, which were organized in the previous months. Also, another important project is the mentorship program, which offers a forum for the ESPGHAN trainee members to meet and also receive some pastoral support from the more senior ESPGHAN members. Last year, actually this year in Milan, during the annual conference, there was a face-to-face meeting in which the mentees were able to meet with their mentors. Also, during the annual meeting, we have a Young ESPGHAN Day, and we have the opportunity to interact with each other and to get to know each other better. Here are the members of the Young ESPGHAN Committee. So if you're not a member yet, please join us. There are many benefits that you can gain from becoming a training member, from research grants to the possibility to take part to educational events. So it's very easy to become a member. You only need an application form, which you can find on the website, and also a CV and a letter of support from a full member. Regarding our next educational events, the next one will be taking place in Porto and is the masterclass on transition from pediatric to adult health. If you want to find more information, you can also download the ESPGHAN application on your telephones. And we would like to meet you all next year during the annual meeting of our society, which will be held in May in Helsinki in Finland. So regarding our webinar guidelines, please mute your microphone and please use the chat box to submit all your questions to the speakers. That being said, I will introduce my colleague, Jose, who is going to introduce our today's webinar speaker. Thank you very much.
Hello, everybody. Thank you, Mara. I'm Jose. I'm also a member of the Young ESPGHAN Committee, and I'm very pleased to introduce to every one of you the Dr. Ana Morais Lopez. She's a pediatric gastroenterologist focused on nutrition and metabolic diseases. She's the head of the Pediatric Nutrition and Metabolic Diseases Unit in La Paz Hospital in Madrid, Spain. And she's very glad to speak to us as an expert on eating disorders, to share her knowledge, and hoping we can learn so much from you, Ana. So thank you very much for everything, and you can go.
Anna, can you please unmute? And if you can choose your background, please, because we see a bit blurry.
Yeah, I don't know how to do it. Because I think you cannot see me properly.
No.
I think it's the lighting. If you have another background, or you just turn
Mara?
with your screen, does it get better?
A ver. No.
On your camera, there is a little arrow on the camera button. You have to activate your green
So you can
screen.
give
Oh,
me
there you go. We can see you now. Thank you very much.
You can see me now.
Yes, perfect.
Okay.
Please continue.
Okay.
Thank you.
That's it. Okay. Thank you very much, and sorry for the inconvenience. Thank you very much, Jose, for your presentation, and thank you to the Young ESPGHAN for inviting me to this webinar series, and congratulations for organizing these very interesting activities. I'm going to share my screen. In the next minutes, we're going to review some general aspects of eating disorders. Okay, can you see my screen?
Yes, thank you.
Yes.
Okay, thank you. So in the next minutes, we're going to review some general aspects of eating disorders, and we are going to focus especially on kids, on young children. Okay, as you know, the pathophysiology of these eating disorders, the ones of adolescents and the ones of younger children, all of them have a biopsychosocial basis, and their etiology, we must find it in an interaction of several factors, underlying factors, previous diseases, previous events, some trigger factors, and maintenance factors. All of them biological, psychological, behavioral, and environmental determinants. This means that the management of these disorders is not only with drugs or with specific single interventions, but they will require a multi-professional approach. They can coexist with other mental or physical conditions, but it's not always they not always coexist. You know very well several kinds of eating disorders. We can distinguish this below: anorexia, bulimia, the binge eating disorder, probably very characteristic of pre-adolescents and adolescents, although in the last years we are seeing them in younger children, in 8-year-olds, 9-year-olds, and these are all characterized by a distorted body image or a negative self-evaluation based on body shape, body image, and weight. As I've said, these are more typical of older children and adolescents, but we have these ones here, like the pica, the rumination, and the ARFID, which we will discuss in deeper detail, which are more characteristic of young children, of kids, although they can track into adolescence and even adulthood, but these are more characteristic of young children. You can see here the general diagnostic criteria of 4 of them, except for ARFID, which we will be focusing on this ARFID in the next slides. So this so-called ARFID, the avoidance restrictive food intake disorder, is a disorder or a group of disorders who share some general characteristics. There is always a nutritional deficiency, quantitative or qualitative. There's not always weight loss. it has definitely an impact on psychosocial relation and social interactions between the child and his family, his peers, etc. But characteristically, there's no distortion of body image and there's no fear of gaining weight. This is a differential finding from anorexia or bulimia. So we have these two groups of disorders, the more, let's say, teenagers ones, although we can see them in childhood, and these ARFID disorders, which has no distortion of body image and are different. So is ARFID something new, something we talk about in very recent years? Well, not so. Probably you remember all these terms from previous years: restrictive eating, neophobia, food aversion, picky eating, to name all these spectrum of disorders related to a failure in the interaction between environment and the child, which conduct to failure to thrive or a nutritional problem. Now, since MSD 5th edition, there's recognized this name of ARFID, avoidance restrictive food intake disorder, who has inside all these previous denominations. And probably it's not very practical for the clinician because inside ARFID there are several subtypes, but at least it's useful to know that this is a group of disorders who are not characterized by distorted body image and which need a multi-professional approach for therapy. These are the diagnostic criteria for ARFID. There is always a persistent failure to meet appropriate nutritional needs, associated with at least one of the following: significant weight loss. It's not completely necessary. It may be one of the associations, but there's not always weight loss. Indeed, some children may be overweight. Or there is a significant nutritional deficiency, for example, iron deficiency, but not faltering growth necessarily. Or there's a dependence on enteral feeding or oral nutrition supplements. Some of these children will need it, not all of them. Or there's a marked interference with psychosocial functioning, a relation with parents, with siblings, with colleagues at school, etc. So this is the first diagnostic criterion. Second, it cannot be explained by lack of food or by cultural practices, etc. It's something different, not related. It's not an eating disorder secondary to not having food. It does not occur exclusively during the course of disorders like anorexia nervosa or bulimia nervosa. These disorders may include in their symptoms ARFID findings, but ARFID is not necessarily, definitely not a part of anorexia or bulimia because there's no evidence of distorted body image. It's not necessary, it's not characteristic from ARFID, although anorexia and bulimia may share some findings of ARFID. And it's not attributable to a concurrent medical condition, but it may take place in the context of another condition. In this case, if we have a medical condition or a mental disorder which associates ARFID findings, it adds severity to the first disorder. But although this medical condition may have worked as a trigger for ARFID, it's not not always if you treat this medical condition, the ARFID is solved. Not necessarily. So ARFID is an entity by itself with failure to meet nutritional needs, interference with psychological functioning. It's not an anorexia. There is not a distorted body image, and it's not attributable to another medical condition. It's something mental. Of course, the term ARFID includes several subtypes, mainly these three subtypes that we can see in the slide. Some children have lack of appetite or lack of interest. These are children with very low appetite. They eat low amounts of foods. They have early satiation. They usually have lack of autonomy for self-feeding. Parents always have to feed them, although they may be at an age in which they should feed themselves. And usually meals take long times during the day. Then we have a second subtype, this sensory-based avoidance, where problems come with organoleptic characteristics: taste, texture of foods, color, smell, appearance, temperature. So they have specific problems with specific characteristics of some foods, and they avoid those foods. These children are very selective in what they eat. And then we have this third subtype, the fear of adverse feeding reactions. Very often, this subtype is related to a previous traumatic experience: choking, vomiting, gastrointestinal discomfort related to eating, allergic reaction, but not always. Sometimes there's no trigger, they're just fear, phagophobia. For example, children with functional dysphagia or with madurative dysphagia, they have fear to eat, although they haven't had any choking, the previous choking episode. So this is this fear is another subtype. Usually, this third subtype is shorter in the evolution. They parents consult to, for example, the gastroenterologist in a shorter time than these two. Especially the first one is it's usually a very long-term disorder. Parents think it's something transitory, that it will resolve within years, but finally it doesn't solve, and the children become malnourished. So it's a disorder by itself. It is to say that some of these subtypes are often related to mental health issues. For example, up to 20-25% of children with the lack of appetite subtype of ARFID have present or show findings of attention deficit and hyperactivity disorder. And up to nearly 20% of children with this sensorial disorder show findings of autistic spectrum disorder. And in this case, the subtype with fear of adverse feeding reactions, up to 60% show symptoms of general anxiety disorders. So quite often they're related to other mental health conditions. So when we want to start a therapy, when we receive in our consultation a child with a probable ARFID, it's very important to make a very, very detailed clinical history, both familiar and personal, because we must identify those factors which have failed in a correct interactions, and we have to find triggers of the disorders. So these details are very important. Things like gestational age, these disorders are more prevalent in preterms. Birth weight, was there neonatal pathology? Did the child need, for example, tube feeding while he was at hospital in the newborn period? Previous diseases, which may have interfered with eating skills: gastroesophageal reflux, celiac disease, eosinophilic esophagitis, etc. Previous need for tube feeding, not in the neonatal period, but in other periods for any condition. Of course, nutritional history. How was the lactation? How was the interaction baby-mother during the lactation? It was human milk or bottle fed. How was complementary feeding? Did parents practice baby-led weaning, or it was with different method? Were there allergies that may cause fear to some foods? What were, during the complementary feeding, what were the preferences of the baby in texture, smell, and taste of foods? Did the child present previous nutritional deficits in any time of his life? And how was previous growth? If it's an adolescence, we must evaluate the rhythm of puberty maturation, etc. How have his eating motor skill been until the moment when we see him in the clinic? Did he need specific therapies like logopedics or whatever? How was the acquisition of autonomy for self-feeding? Was it easy, or hasn't it been reached at all? Did he require prolonged use of bottle or dummy to eat? And referring to psychosocial history, how neurodevelopment has been? Does he show avoidance behaviors? How are family interactions? How is parents and siblings eating behavior? Sometimes these behaviors are not correct, or parents and family change their eating habits to adapt to this new member, this new child who doesn't like very much to eat. So all family meals and whole energy intake is wrong, is distorted. About diet assessment in the clinical history, these children frequently show a high intake of carbohydrates and sugars and processed foods because they don't like to eat. So they eat things that end with their hunger sensation quickly, and then unless they are very hungry, they don't want to eat again. They usually have a low intake of veggies and protein-rich foods because they're more difficult to chew. Definitely, when we assess their diet, we must know that they're under nutritional risk if the intake of any nutrient is under 80% of recommendations. It's useful to apply techniques like the 3-day register, 24-hour recall, or the food frequency questionnaire to assess the quality of the diet, not only in the child, but in parents as well, the whole family. We must ask about foods and drinks consumed, portion sizes, preferred or avoided foods. Does he take any nutritional supplements or enriched food or drinks? And how are the meals? How many hours in the day are dedicated to feed the child? In which place? Is it necessary television or whatever distraction to get the child to eat, etc. We must know that depending on the avoided foods, there's a higher risk of nutritional deficiency. For example, with cereals, there's a risk of a deficiency in carbohydrates, in fiber. In milk and dairy products and meat, there's a risk in deficiency for calcium, proteins, some vitamins and minerals, iron. If fish is avoided, there's a risk of a deficiency in omega-3 fatty acids, in vitamin D. If fruits and vegetables are avoided, apart from fiber, folic acid and vitamin C may be under risk. And if fats in general are avoided, which is not very frequent, but some liposoluble vitamins and calorie intake in general may be compromised. About physical exam, especially if the children comes to our clinic with a very long time disorder, we must check vital signs, temperature, blood pressure, heart rate. We will make a general exam looking for nutritional signs in the skin, in the hair, teeth, tongue, etc. We would check Tanner stage, especially in pre-teenagers and teenagers. And of course, we will make anthropometry and, if we can, body composition assessment using the techniques we have available, anthropometry, bioimpedance analysis, whatever. So complete physical exam. We must be very aware for red flags for organic pathology because it can be concomitant or some organic pathology may have acted as a trigger. For example, is there a history of recurrent infections, crying or pain while eating, history of choking episodes? Are the symptoms that this child show related with the introduction of any new food or any specific foods? Is there recurrent vomiting, diarrhea, or constipation related to some kind of foods? Have there been changes in the temperament, in the character of the child, or are they related to food, to feeding the child? Is there developmental delay, chronic respiratory symptoms, jaundice, pallor, cyanosis, edema, or is there a severe malnutrition? That's probably there's probably some organic pathology related to the ARFID. We must ask for these logopedic explorations, the oral skills, how were they acquired by the child, the swallowing skills, we must explore them, especially in young children. And if we can, we must examine the sensorial relation with foods, taste, and is the child capable of distinguishing different tastes and textures? Does he have the same abilities with liquid and solid foods in his mouth? Does he retain the food, for example, under the tongue or inside the cheeks? Does he retch with certain stimuli, for example, when you touch his lips or with the smell of foods? No? Does he retch with that? Those are very important findings in the physical and functional exam. And if we see them, we must ask parents, when did this start? Why did this start? Is this very frequent with all the foods, or is it just episodic? So very complete clinical history. Laboratory exams are not always necessary, depending on nutritional detriment and possible comorbidities. We may consider, not in all children, but maybe in some of them, complete blood count, acute phase reactants, especially when we suspect organic pathology associated. Electrolytes, thyroid profile, celiac disease screening, hormones, vitamins, minerals, lipid profile, electrocardiography, bone density in older children with very serious growth failure, and depending on the findings in the exploration, in some of them, video fluoroscopy or endoscopy, or etc., depending on the clinical history findings. And what can we say about general therapy of these disorders? Very important. It has always to be placed by a multi-professional team. Don't think that we alone, the gastroenterologists, can help and solve an ARFID, especially in a young child. We will always need the participation of the mental health team, psychiatry and psychology, the dietitian, very frequent logopeda, the speech therapist, endocrinologist, depending on the findings, the nurse, and sometimes the social worker, the occupational therapist, etc. And very important, the family is part of the therapy team. And specifically, therapy nowadays, we know it has been demonstrated by some studies that family-based therapy is the best way to treat these children. Here you have in these terrible slides the main objectives of therapy and the way we can achieve them. You know, it's important in general for all these disorders, eating disorders, not only for ARFID, to be capable to detect individuals at risk or with established eating disorders. And this is only possible if we raise awareness among society, among pediatricians, primary care pediatricians, about the red flags that can indicate an eating disorders, and to ensure that it's a useful and an effective referral to the specific unit to treat these disorders. We've said that we must obtain a very detailed medical history with an interview based on empathy, on active listening. Very frequently, these parents have a lot of things to tell you, a long story with a lot of negative experience. We must actively listen to them. We must determine current nutritional status, of course, and rule out other diagnoses. So we must have time to do a correct and thorough nutritional assessment, sometimes complementary laboratory tests. We must design a realistic nutritional rehabilitation plan, appropriate and individualized for the child. Probably, if this disorder have been evolutioning for years, we will not solve it in 2 months or 3 months. We must be realistic with those family. We must know what eating habits that family had prior to the start of the disorder. We must correctly estimate the nutritional requirements of the child to calculate a realistic therapeutic plan. We must set an individual goal of minimum weight, of minimum body mass index to be achieved at each stage of the treatment. And for that, we must know previous health status, previous anthropometry, previous pubertal maturation, etc. We must decide together, once again, with the mental health team, which treatment regimen is most appropriate. Does this patient need hospitalization, partial or total, or can he be managed completely ambulatory, in an ambulatory way? We must carry out nutritional education with the family, promoting a healthy and varied diet. We must do a motivational interview, explain, talk to parents and also to children and adolescents about what's food for, what are the realities of food, what are the nutritional requirements, what healthy eating is, and eliminate myths about foods. We must indicate oral or enteral supplementation when it has to be indicated. We must prevent, in some of these children who are very malnourished, we must prevent refeeding syndrome, so must be aware which patients are under risk of refeeding syndrome and take the correct measures for prevention. So, go slowly with the nutritional program. We must treat the most common physical comorbidities suggested by clinical history. We must promote healthy physical exercise. Some of these patients, in general, eating disorders are hyperactive or they over exercise themselves, especially those not in ARFID specifically, but in anorexia or bulimia is quite frequently the hyper exercise. So we must orientate these patients for healthy physical activity, always controlled and personalized. We must detect when they have compensatory hyperactivity, and when their nutritional status is partially correct, we must encourage them to healthy exercise, non-obsessive exercise, but healthy lifestyle, and that includes exercise. We must ensure continuity in objectives already achieved, so we must detect relapses as early as possible. So we must establish consensual periodic visits so we can check and detect difficulties or relapses of the disorder. It's as a part of nutrition team objectives, not only for mental health professionals, we must support that child and his family regarding to the emotions that come with eating, with body image, with purgative behaviors. We must be hand to hand with a mental health team. And we will have to monitor that child and his family as long as necessary until the disorder is in a sustained remission. So sometimes that's very long follow-up. As we have said, in therapy, several actors. There's a psychosocial therapy, which there are several kinds: behavioral, cognitive behavioral, and family-based therapy. These last two are the ones who have demonstrated higher efficacy, especially family-based therapy. The family becomes a main actor to achieve the therapeutic goals. Then we have some pharmacological therapies. some of them depending on the ARFID subtype. For example, in the lack of appetite subtype and the lack of interest for food subtype is quite frequent to use, for example, cyproheptadine or other anti-H1. Depending on other comorbidities, anxiety, depression, neurodisability, we may need different drugs. For example, for anxiety, which is the most frequent mental health comorbidity, we may use, or the mental health team may use, specific inhibitors of serotonin recaptation, like sertraline, the most frequently used in children, sometimes benzodiazepines at the beginning of the therapy, or risperidone, etc. It's more controversial, the treatment with methylphenidate in those children with ARFID that show findings of deficit of attention and hyperactivity disorder, because, as you very well know, methylphenidate as a side effect has decreased appetite. So it has to be very well evaluated, but there are children that need the therapy with methylphenidate. So we will have to talk with the mental health team to discuss about regimen, therapy, etc. Of course, if there are some organic comorbidities, we must treat them. And then we have the nutritional therapy, which may include therapy for micronutrients deficiency. It may include an increase of calorie intake through energy-dense meals without increasing serving size in the beginning. We may need oral nutrition supplements, and sometimes there may be an indication for tube feeding. As ARFID and eating disorders are disorders related to a failure in their relationship with food, with parents, with family, very often tube feeding distracts in all that process. And sometimes it's the use of a nasogastric tube, for example, is the trigger of an ARFID or an eating disorders. But there's a group of children, a little group of children, which will not improve unless we help them with tube feeding for 2 months, 3 months, and then we make a correct regimen to be went from tube feeding. So some children who do not achieve 80% of their requirements orally, who present at first place with moderate to severe malnutrition, or those with a very long total meal time during the day, or with great anxiety and conflict, sometimes we have to reset, not eat, feed that child through a nasogastric tube, and start again with new techniques, with a new approach to food, etc. Very few patients, but some of them need that approach. And in all patients, but especially in those ones, we will need the logopeda, the speech therapist, to help the child in the progression in textures and serving sizes, to make an approach beginning with best accepted foods and progressively adding new foods in accordance with child, family, and therapist. So family is highly involved in this process. Speech therapists also help to establish a fun and playful relationship with food. They make indications to improve oromotor skills through specific interventions, and they also are capable of giving recommendations on how to improve the presentation of foods to help that child to have a better mental representation of foods, and hoping that will lead to a better acceptance of food, to change the mental image that the child has of certain foods that he's been avoiding. And that's very specific of the speech therapist, the logopeda professional. So just now to finish, remember that eating disorders have a very complex and multifactorial pathogenesis that must be understood for a correct approach. We cannot be alone in this. as family cannot be alone in this. There's a concurrence of biological, anatomical, emotional, etc. factors that makes necessary the participation of professionals from several fields. For us pediatricians, us gastroenterologists, to put words to a distortion in the relationship between a child and his parents is a challenge for us. We don't. It's hard for us to understand that concept of putting into words that failure in the relationship. We know about infectious diseases, about congenital defects, but these things are difficult for us. So it's very important for us to understand them and to lean on the mental health professionals. We know that current classifications of eating disorders are not very precise, and clinical guidelines and protocols are unfortunately lacking. And it's essential to design a correct nutritional assessment and nutritional care plan alongside with the rest of the team, and paying a lot of attention to mental health recommendations. Always team working. All of us, the psychiatry, nurse, the speech therapist, and the gastroenterologist must give the same message, must drive this child and his family in the same direction, so he can improve, he can meet the goals. And that's all from me. These are some interesting references that you may like to read. And once again, thank you very much for inviting me. And I think we have a few minutes for discussion. Thank you very much.
Great, thank you very, very much for your engaging presentation on eating disorders. I think we all found your insights very valuable, and we appreciated your approach about this important issue. From my end, what I would like to ask is, what are the main challenges you face when treating children with eating disorders in an inpatient setting compared to an outpatient setting or community-based setting, and how do these challenges impact the outcomes of the treatment?
Okay, nowadays we tend to manage these patients with the least admissions to hospital as possible. Anytime we can, we try to manage them, to approach them in an external way with visits to the clinic, and that implies the family. I mean, the family is very important. Parents are very important actors in this. So we must design a plan with compromises from the child, from the healthcare professional, and from parents, because parents must become the therapists at home. So it's very, very important to integrate them in the therapy team. So sometimes are parents who need psychological support. Sometimes they need directions to change behaviors at home. So, but at the same time, although that seems something very difficult, because you can say, I never know what happens in that house, but those techniques have proven to be the best ones, because the objective is to change the whole family dynamics, not only to make the child gain weight or whatever, or help him to swallow correctly. We must change all the family dynamics, and for that is very important to have parents as part of a therapeutic team.
Also, another question from participants. So there's a question by Lucinda asking, may you give us some recommendations of how to manage children with autism and severe sensory-based avoidance if we don't have a speech therapist in our hospital? Because apparently we all have, different background with different resources in our hospitals. So that questions comes from Lucinda.
Yes. Well, it is to say that, of course, not all of us have a speech therapist or even dietitians in our institutions. But, in this case, the autism spectrum disorders associated with ARFID, speech therapists are one of the main actors because they have specific skills to manage this. But anyway, you can start with some, you must start with the foods preferred by the child and only those foods. And you have to ask him, okay, which foods you don't like, which foods you don't want to eat, why don't you want to eat this food, and try to change the image of those foods that he has in his head, trying to change that image. Sometimes, for example, they associate chicken with a little tiny animal that he's going to eat, so he doesn't want, and we have to change that, to talk to him, okay, chicken meat is not the same as the little animal you have. These are different things. So you have to make treats with them so they accept first to see the food, changing their mental image of the food, then to touch the food, smell the food, relate that to good experience, not to those bad experience or bad thinking that he previously had, and in the last time to taste that food. So it's quite a long way to run and difficult, and that's why at the same time they may need some kind of nutritional supplements or whatever, because those are the most difficult children, and you have to go one food at a time with all the process, changing the mental image of that food, making treats with them, with a child, starting touching. So it's quite a long process. So at the same time, you must talk to family, to parents, to work with the foods that are preferred by the child, to increase the energy density with preparations with sauces or olive oil or whatever in the foods he likes, to keep working with the foods he avoids. But it's quite, it's a day-by-day work, but it's quite difficult. And speech therapists are specialized in that. They know very well how to do that.
Great. Another question by Nicoletta is asking, would you suggest increasing calorie intake for the lack of interest or lack of appetite subtype? And if yes, by how many calories?
Okay. In the lack of appetite, lack of interest is one of the main measures to increase energy density of foods, because if by that means you get to improve nutritional status of the child, then that secondarily always conducts to a higher appetite. If you improve muscle mass, lean mass, the resting metabolic rate increases, and that increases appetite in the medium and long term. So yes, it's a useful measure for children with lack of appetite to increase or to give him more energetically dense foods. And in which amount? Well, that's what you have to calculate with a nutritional assessment, with a very good nutritional assessment, which must include, as always, if it's possible, a body composition assessment, because you may have children overweight or normal weight, but with an excess of fat body mass secondary to the kind of foods they eat, and with low muscle mass or low lean body mass. So you must always evaluate in these children body composition to correctly estimate their protein and calorie needs, definitely.
Great, thank you. Another question. Do you have children, or what is the threshold to consider gastrostomy insertion in children with ARFID?
There's not a clear limit when you can say, okay, until yesterday you could live without a G-tube, but there cannot be any more days without a gastrostomy. From today, you need the gastrostomy. That's not by that. You have always to look back on the evolution, and it's a cumulative science that that makes the balance inclinate favor or against the gastrostomy. Obviously, a child that after, let's say, 6 to 12 months, you may have been working with him, improving his variety of foods, his calorie intake, but still under 6 or 12 months, he's still underweight, or his height growth has been stopped. Those children are candidates for gastrostomy, especially in those children that you may anticipate that therapy will be continuing for a long time. I mean, you have gone through some good achievements in therapy, but you think, okay, this children is malnourished, he's improving in his skills, but he's still malnourished, and I think he will be the same for the next year. You have to talk to parents about gastrostomy in those cases, but there's not a fixed threshold. It's very individualized, the indication for gastrostomy, definitely.
Great. There is a lot of interest and a lot of questions in the chat box, so I think we do have a, if it's fine with you, we can go through a couple of them before.
Yeah, or of course then by email or anything, we can, if there are a lot of them, we can answer them in the next days or whatever, if you prefer.
Thank you.
But yes, of course.
A question from Olga. For inpatient setting, what criteria do you consider most important in order to safely discharge the child with ARFID, and which then would effectively prevent future readmission, is clarified?
Okay, you know, I think very often criteria for admission to hospital are mainly of two types of criteria. One is nutritional status. Very severely malnourished children that may need at least for some weeks tube feeding, for example, or who are at great risk of refeeding syndrome. That's one of the indications. But I think more frequently the indication is the absolute incapacity of parents to manage that situation at home. Sometimes parents come completely overwhelmed by situation. Meals at home are violent, full of anxiety, and it's a very, very bad experience, meals at home. Those children, and especially those parents, need admission to hospital. Now, what we said about reset. And in hospital, you not only have to work with the child, you have to work with parents to change the way they approach to their kid regarding meals, the way they feed their child. Sometimes you have to change their behavior, say, don't force the child to eat, change the presentation of the food, change the atmosphere. So sometimes admission is motivated by those that kind of things, for example. And when parents feel that they can become principal actors, that they can control their own anxiety, that may be the moment for discharge. And to prevent future hospital, you have to make a very close follow-up, sometimes every week at the beginning, then every 2 weeks, every month, but at the beginning, a very, very close follow-up.
One more question from Anne-Marie, our chair from the committee. Could you advise any resources available for participants in the audience that wish to learn more about the therapies on RFID, especially if they don't have the possibility of MDT, that they don't have the possibility of multidisciplinary teams in order to get more support?
Okay. Yes, I think in the references there were some I can share with you, so by email or whatever, some resources that you can check. But we all have to admit that the management of these disorders must necessarily be multidisciplinary. I mean, we are not psychiatrists, we are not psychologists, we are not speech therapists. And if we say, okay, I want to manage these children in my institution, the first effort is to collect or recruit other professionals to form a team. That's very necessary. I wish I could say it in a different way, that it could be different, but only for the gastroenterologist is very, very difficult. I mean, the first step, you can check the resources, you can start working with your patients, but always having in mind that the objective is to form a multidisciplinary team. Always, that must be as a future goal, always.
Thank you very much.
I can share with you some resources, and we can share it by email with the participants, of course.
That would be very helpful. If we can spend 2 more minutes, actually, because we were running late by 5 minutes, so
yeah,
be helpful. So a question from Badr. In your experience, how can we treat kids with color picky eating disorders? And I came across another question about neophobia as well.
Okay. Well, one thing is neophobia, which is that fear to new foods, which is not related to texture, to color, or whatever. It's just an irrational fear. It's very characteristic of lower growth stages, because, for example, an infant has a very fast growing rate. When he reaches, let's say, 2 years of age, growth velocity is not so high, and 2-3-year-olds still don't have that level of activity of 6-year-olds that run and play soccer or whatever. So they don't need so much food, really, and that makes them become selective and sometimes picky eaters. They don't want to taste new foods because they don't need to. So for neophobic children, it's very important at home to offer that food repeatedly. Sometimes one food must be offered up to 20 times before they take it to their mouth. It's very important, the example, which children mainly do not eat veggies. Children from parents who don't eat veggies, mainly. So it's very important that all the family eats that variety of foods, putting that food in the plate of the child many times until, because if there's a moment that he, for whatever reason, feels higher appetite, if he has the chance, he will take that food. But if he's not offered those foods, he will never taste them. So repetitive offer for the neophobia. And for the color, okay, once again, it's very important, the example, everybody around you eating that color you don't want to eat, but we have to investigate why. Sometimes they don't want to eat red foods because they remind it of blood, for example, because one day they have a nose bleeding and they swallowed blood, and that was red, and that was very nasty, and they don't want nothing red because it's like blood. We have to change that image in the brain of the child. So to separate one thing from food, to combine that food with other foods. Sometimes it's very, very difficult. There are adolescents and even adults who separate green peas when they find them, for example, in a plate of, or in a dish of rice, for example, they pick the piece and they collect it outside the plate. So sometimes it's difficult, but we have to go to the roots. Why do you hate that color? What's the reminder that makes you hate that color? And we have to change that. In this case, it's not a question of force him to taste that so that he sees that taste is good. No, we have to change the association. And sometimes that's a hard work for some children.
Great. And one last question, if you don't mind, before we close. There's a question from Giovanna asking, what is the most successful treatment strategy for rumination syndrome in your experience? And if you feel that this can coexist with other eating disorders, such as bulimia in some cases?
Yes, in some cases it can be a part of the clinical manifestations of bulimia, but not always. If it's a part of a bulimia nervosa that has a very specific psychiatry protocol therapy, and everything improves within as bulimia itself improves. For children with rumination syndrome, it's very important to rule out organic disorders like gastroesophageal reflux or eosinophilic esophagitis, etc. And it's very, very useful, the psychotherapy with these children. We must recommend parents to avoid to give too much attention to the rumination episode, to shout at the child when he ruminates. So, it's very useful, the management with the muscular relaxation techniques. So when the child must learn how to control that need for ruminate when he's eating. And that's very specific of mental health professionals. It's more difficult for the gastroenterologist because it's not a question of giving, let's say, domperidone or whatever. No. Once we have ruled out organic diseases, it's a question of relaxation when the child feels that need of coming up with the food again. So it's very specific from mental health professionals with relaxation techniques specifically.
Great, thank you very, very much. Again, I think we run out of time. So thank you all for joining us today, and we appreciate that there was a lot of interest in this session. And special thanks again to our speaker that you shared your valuable insights on this topic of eating disorders. And as you said, if the audience has any further question or any additional resources, to feel free to reach out, either us or directly to you. And we hope you found this webinar informative. Have a good day and look forward to seeing you in our next event.
Okay, thank you very much, everyone.
Thank you.
Thank you very much, Anna. Thank you.
Bye-bye.